Welcome to the first episode of How I Do That, a neurointervention educational series, episode 1 presented by Prof. Dr. Osama Yassin Mansour Sow, Professor of Neurointervention in the Stroke and Neurointervention Division at SMUHA Campus, Alexandria University. Case Overview EU. This episode focuses on a PICA dissecting aneurysm treated with endovascular therapy using a flow diverter. We will walk through the clinical reasoning, procedural strategy, and technical execution step by step. Endorsement. This educational series is endorsed by 5 leading societies were Egyptian Board of Neurointervention, Egyptian Society of Neurology, Psychiatry and Neurosurgery, Egyptian Society for Treatment by Interventional Radiology, Egyptian Society of Neurological Surgeons, Egyptian Society of Neurointervention and Stroke. The series also features international collaboration through Mina Sino. The goal of this presentation is to share a real-world case in a structured, reproducible format, is Seruma, offering colleagues a transparent look at decision-making in complex neurointerventional procedures. This slide presents our clinical case at a glance. Patient, a 58-year-old female who presented with sudden onset headache that rapidly deteriorated over 24 hours to include drowsiness and right-sided hemiparesis before arriving at our hospital. This acute neurological decline raised immediate concern for a hemorrhagic event. Clinical grading. On assessment, the patient was classified as Hunt and Hess grade 3, indicating drowsiness with mild focal neurological deficit, set class a moderate to severe grade that warrants urgent intervention. CT imaging revealed Fisher grade 4 subarachnoid hemorrhage, signifying diffuse thick clot with intraventricular hemorrhage, which carries a high risk of vasospasm. Imaging. Representative imaging on the right side of the slide shows the CT and angiographic findings that guided our treatment planning. Time to treat. The onset to groin and door to groin times are key metrics for this case, reflecting the urgency of our endovascular response. Clinical question. The central question driving this presentation is, what is the optimal endovascular strategy for this patient? Considering her grade, imaging findings, and clinical trajectory. We will walk through our decision-making process and procedural approach in the slides that follow. DSA and 3D volumetric reconstruction showed dissecting PICA aneurysm in junction between telovulotonsillar segment P4 and tonsillomedullary segment P3, and this anatomical location carries some important clinical implications. 1. The intraventricular component of hemorrhage as shown in CT with fourth ventricular hemorrhage. 2. Minor challenges for both surgery and EVT. From anatomical point of view, rupture of an aneurysm in the distal PICA segments typically manifests as a devastating subarachnoid hemorrhage characterized by a high incidence of intraventricular extension into the fourth ventricle, often precipitating acute obstructive hydrocephalus, necessitating emergent cerebrospinal fluid diversion. From an interventional perspective, the P3 tusus flow segment's characteristic caudal loop and extreme tortuosity demand high technical precision during endovascular navigation, while the P4 telolo-flow segment's proximity to the inferior medullary velum makes surgical access via a suboccipital approach viable, yet complicated by the small vessel diameter, which limits options for bypass if the parent artery cannot be spared. These cases often require a delicate balance between total sac occlusion and the preservation of distal flow to avoid cerebellar infarction and debilitating lower cranial nerve palsies. Procedure description: flow diverter deployment in left PICA preparation and anesthesia. The patient is brought to the neuroangiography suite and placed under general anesthesia SOAG LCAS-E as indicated in the pre-procedural plan. Systemic anticoagulation is administered using a standard heparin protocol to maintain an appropriate activated clotting time ascites throughout the procedure. Antiplatelet regimen was described previously. Vascular access. Vascular access is obtained via the femoral artery using a 6F flow arterial sheath. Rayler vein to diameter or chimio methanate of Tyrrell ingemoral Braffington million seri material for Pochimana, the diameter flow, the diameter 60 millia in the diameter Potiman, guide catheter placement. A 6F guider soft tip guide catheter is introduced through the femoral sheath. The 6F guide catheter is carefully navigated up into the left vertebral artery V4 segment to provide stable support for the intracranial intervention. Microcatheter navigation under continuous fluoroscopic guidance and road mapping, a Medtronic Phenom 27 microcatheter paired with an appropriate microwire 2 is introduced through the 6F guide catheter. The microcatheter is carefully navigated out of the left vertebral artery and selectively advanced into the left posterior inferior cerebellar artery pomeramsal. The tip of the Phenom 27 is positioned distally, safely past the neck of the target aneurysm or lesion. This slide distills the 5 key learning points from the case of a 58-year-old female with a ruptured PICA dissecting aneurysm, Hunt and Hess grade 3, Fisher 4, treated with endovascular therapy using a flow diverter. 1. Technical skill. The procedure was performed via femoral access using a 6F sheath. A 6F guider soft tip catheter was used as the guide catheter, and a Phenom 27 microcatheter etotromcomatotocemia was selected for device delivery. The flow diverter deployed was a pipeline flex with shield technology, size 2.50 x 14 Navigating a microcatheter through the posterior circulation to the PICA origin demands precise catheter control. The tortuous vertebrobasilar anatomy and small caliber of PICA make this technically demanding. The pipeline shield's phosphorylcholine surface modification reduces thromboembolic risk, which is especially valuable in small caliber posterior circulation vessels. 2. Decision making. The decision to use a flow diverter rather than coiling or surgical clipping for a dissecting PICA aneurysm reflects several considerations. Dissecting aneurysms involve the vessel wall itself, making them poorly suited for simple coil embolization, which would not reconstruct the diseased wall. A flow diverter provides vessel wall reconstruction while preserving flow through PICA acetatum, critical for preventing lateral medullary or cerebellar infarction. The choice to proceed urgently was driven by the Hunt and Hess grade 3 presentation with active subarachnoid hemorrhage. The patient first received an external ventricular drain (EVD) for hydrocephalus management, then was loaded with dual antiplatelet therapy, Sibrin 200 mg and ticagrelor 180 mg 1 hour before the procedure, balancing the hemorrhagic risk of antiplatelet loading in the setting of acute SAH against the thrombotic risk of deploying a flow diverter without adequate platelet inhibition. 3. Patient selection. This case illustrates the criteria for selecting flow diversion in ruptured posterior circulation dissecting aneurysms. The patient's imaging showed a dissecting morphology at the PICA segment, cerebral ceria not a saccular aneurysm, amenable to standard coiling. Fisher grade 4 with intraventricular hemorrhage confirmed severe SAH requiring definitive aneurysm treatment. The fact that EVD was placed first allowed CSF diversion and ICP management before committing to dual antiplatelet therapy. Patient selection for flow diversion in the acute rupture setting requires weighing aneurysm morphology, isocelatin versus saccular, vessel anatomy, can the microcatheter and device reach the target safely, and the ability to manage the dual antiplatelet requirement in a hemorrhagic patient. 4. Complicatum avoidance. The key complications to anticipate in this scenario include thromboembolic events during or after flow diverter deployment, CZ mitigated by the shield technology coating and adequate dual antiplatelet loading, CZ hemorrhagic complications from antiplatelet therapy, patient with active SAH managed by placing EVD first and timing the antiplatelet load to minimize the window of exposure, C. Perforator occlusion. The PICA itself and small brainstem perforators are at risk when deploying a flow diverter in the posterior circulation. Careful device sizing, 2.5T x 14 EMEA ensures coverage of the disease segment without unnecessary extension. Procedural vessel injury, general anesthesia was chosen over conscious sedation to eliminate patient movement during navigation of the posterior circulation. No balloon guide catheter was used, which is typical for posterior circulation cases where proximal flow arrest is less practical. 5. Follow-up and outcome. Follow-up imaging was performed at 6 months. The goal of follow-up after flow diverter placement is to confirm progressive aneurysm thrombosis, patency of the parent vessel and PICA, and absence of in-stent stenosis. Dual antiplatelet therapy is typically maintained for 3 to 6 months post-procedure, then transitioned to aspirin monotherapy based on angiographic results. Clinical follow-up tracks neurological recovery, the diagnosis in a Hunt and Hess grade 3 patient. The trajectory from drowsiness and hemiparesis to functional independence is the ultimate outcome measure. Case complexity. This case is rated 4 out of 5 stars, reflecting the challenges of posterior circulation access, flow diversion in the acute rupture setting, and the need to balance antiplatelet therapy against active hemorrhage. Thank you, and see you in the next episode with another case by one of the leading regional experts. See you soon.